My name is Mallory Johnson, and I am one of the co-directors of CFAR, and I'm very excited to get to kick off today's seminar. The way that we structure these is that we have an early stage investigator from our CFAR that we feature first, who gives a taste of their research in a short talk, and then that person, that investigator, introduces our guest speaker, who today is Dr. Michael Mugavero, and you'll hear more about about him in a moment. But for now, I get the honor of introducing our in-house early stage investigator who's going to kick off today. So today we're going to hear from Dr. Andrew Kerkhoff, and he's an infectious disease physician, HIV primary care provider, and fourth-year research fellow in the Division of HIV Infectious Diseases and Global Medicine at Zuckerberg San Francisco General Hospital here at UCSF. His longstanding research, longstanding research interest is in the evaluation of tools and approaches to improve the diagnosis of HIV-associated tuberculosis. His current research is based in Zambia in collaboration with the Center for Infectious Disease Research in Zambia, and seeks to apply implementation science methods to improve the efficiency and effectiveness of TB case finding and diagnostic strategies in resource limited settings. I also want to highlight that in 2020, Andrew was selected to receive the CFAR Research Excellence Award in Clinical Science, really highlighting his extraordinary work as an early stage investigator. So we're excited to hear from Andrew, and I will let Andrew take it away, and we will have time, if all goes well, for a question or two for Andrew before moving to Dr. Mugavero's talk. So Andrew, take it away.
Wonderful. Thank you so much, Mallory, for the very kind introduction, and good morning to everyone who's tuning in today. It's my absolute pleasure to present some of my research as part of January's CFAR seminar. So my talk is entitled Evaluating Patients' Preferences for Improving Discrete Choice Experiment, or Improving TB Diagnostic Services in Zambia, a discrete choice experiment. So tuberculosis is the leading infectious cause of death globally and the leading cause of death among persons living with HIV. And for persons with TB in high burden settings, the pathway to care engagement may be long and complex, as they will often face numerous barriers to seeking care for their illness, as well as to accessing TB diagnostic services. And delayed and missed TB diagnoses contribute to ongoing community transmission, as well as poor clinical outcomes, and this ultimately undermines progress towards global targets. So in order to design interventions that aim to improve health-seeking behavior for TB and improve access to TB diagnostic services, it's important to understand what intervention components would be most preferred and acceptable to the individuals that we're trying to reach. However, patients' preferences for improving TB diagnosis and care services are quite poorly understood. Therefore, we undertook a discrete choice experiment among newly diagnosed TB patients in Zambia to understand their preferences for improving TB service attributes that may ultimately accelerate and improve TB care engagement. So this study was cross-sectional in design, and all participants completed a structured survey that captured sociodemographic details and health-seeking behaviors, and they also completed a discrete choice experiment. So this study was undertaken at 2 public health facilities in Lusaka, including a high-volume community TB clinic, as well as a very large tertiary referral hospital. And we enrolled adults greater than 18 years of age who had been newly initiated on TB therapy in the prior 2 weeks. And we aimed to enroll 400 participants to allow for sufficient power to undertake subgroup analysis. So for those of you who may not be as familiar with DCEs, these are an increasingly utilized quantitative technique that's been adapted from the business field to measure stakeholders' preferences for products and service features. And this can ultimately help us to understand what is most desired or valued by stakeholders, and ultimately how products and services may perform when you implement them. So in brief, they work by first taking a product or service and breaking it down into its core components, and these are known as attributes. And then the respective attribute features, which are known as levels, that we want to test within those attributes. We then show participants a series of choice tasks and have them choose between 2 or more different concepts, which vary on these different product features. And we then ask them to choose their most preferred concept. So for example, based on what you've seen in front of you, would you prefer product A or product B? And then based on a participant's response to several of these different choice tasks, we can then calculate how much unique value they assign to each of these different features. So shown here is the DCE that we administered, and we started by asking participants to imagine that they were once again sick with their illness, and then asked them which hypothetical facility they'd prefer to attend. And the facilities differed according to 2 to 3 levels for each of the 7 attributes shown here to the right. And the primary outcome was ultimately to determine the relative importance of service attributes and the utilities of specific facility attribute features. And we determined these using hierarchical Bayesian model within Sawtooth software. So of 401 participants enrolled, 358 had complete DCE results and were included. Participants tended to be young, in their mid-30s. The majority were male, and about half were HIV positive. Participants tended to be quite poor, with a median monthly household income of approximately $100 US. And approximately 60% were enrolled from the community TB clinic, while 40% were enrolled from a tertiary hospital. So overall, the strongest preferences were seen for the TB test result attribute, where patients very strongly preferred same-day TB testing results compared to either being called with the results or being asked to return another day to collect the results. Patients also showed very strong preferences for less time spent at a facility waiting and undergoing evaluation, as well as facilities that were closer to their home. We also found smaller but still important preferences for a facility that offered small financial incentives to undergo TB testing, as well as facilities that might offer greater confidentiality. Notably, no strong preferences were observed for the sex of the provider or facilities' hours of operation. So another way to look at these results is to examine the relative importance of the actual overall attributes. And as we can see, the speed and method of TB test result notification was the most important attribute, shown here in turquoise, and was more than twice as preferred as the next most preferred attributes, which were time spent at the facility, which shown as purple, and a facility's distance from home, shown here in salmon. And notably, preferences did not meaningfully differ according to HIV status or sex. So next, we used the choice simulator within Sawtooth software to determine the additional distance participants would be willing to travel in order to access a facility that offered these enhanced features. And we can see here that patients were willing to travel an additional 7.5 kilometers to access same-day TB testing results, despite being required to wait an additional 3 hours that's needed to process and return their results. They also indicated a willingness to travel up to 4 kilometers further in order to access a facility offering small financial incentives, and more than 2 kilometers further in order to access a facility offering enhanced confidentiality. So finally, we undertook a simulation exercise to understand how preferred a facility providing one or more of these enhanced features would be compared to a facility offering the usual care. So for the usual care health facility, we made several assumptions, which are summarized here on the right. Well, for the enhanced care facility, we assumed that it may not be feasible to implement different interventions at all first level facilities, and thus the more centralized enhanced facility would need to be 2 kilometers further away from a participant's home than the usual care facility. And so overall, we found that 2/3 of patients would prefer to actually travel twice as far to a centralized facility that offered same-day TB testing results, while only 1/3 would actually choose the usual care facility closer to their home. Even more patients would be predicted to choose the enhanced facility when same-day TB testing results are combined with greater confidentiality. However, the most preferred TB care engagement strategy was to combine same-day TB testing results with a small financial incentive, with nearly 80% of participants preferring the enhanced facility offering those services combined to a usual care facility closer to their home. So to briefly summarize our key findings, we found that same-day TB testing was more than twice as preferred by patients compared to any other single strategy to enhance existing TB services in Zambia. However, shorter wait times and facilities closer to home were still strongly preferred. Notably, there was no evidence that preferences meaningfully differed according to HIV status or sex. We determined that patients would be willing to travel up to 7.5 kilometers further to access a facility offering same-day TB testing. And finally, we found that patient preferences were optimized by combining same-day TB testing results with either a small financial incentive or enhanced confidentiality, and such a multi-component strategy could further improve TB care engagement. Therefore, we conclude that incorporating patients' preferences into TB services and TB case fighting strategies, especially rapid testing with same-day results, may facilitate earlier TB care engagement in high-burden settings. And I'd just like to finish my talk by thanking all of the following persons for their important contribution to this study and mentorship, especially my collaborators at CIDRS in Zambia. I'd also like to thank the UCSF Gladstone CFAR for providing funding to support this work. And I'd like to thank you all for your attention, and I'd now be very happy to answer any questions that anyone might have. Thank you.
Fantastic. Thank you, Andrew. And wow, right on time. So that was great. So so we have time for a couple of questions. I can't see everyone's video at once. Looks like maybe I can now. So, but feel free to unmute yourself. You can also put the question into the chat, whatever you prefer. But we do have the luxury of live questions. So who has the first question?
Hi, Andrew. My name is Jose Gutierrez. I'm a first-year postdoc at UCSF, and recently defended my PhD using discrete choice experiments, determining preferences for prep among military MSM. Loved your talk. It's very interesting. I was super curious to see if you were able to do any cluster analysis or like latent class analysis on some of the preferences to see if certain groups tended to cluster by preference. I've found that within my own experiment, there's an overwhelming dominating preference for a specific one, but it seemed to drown out some of the smaller clusters of preferences that would actually improve overall share preference if we were to offer multiple ones. So I didn't know if you were able to find something similar in your experiment.
Yeah, absolutely. That's thank you for sharing some of your own work. It sounds fascinating. I'd love to talk offline about it at some point. The short answer is that yes, have done the latent class analyses, and there are different segments that clearly emerge. Same-day TB testing results sort of dominate 2 of those classes. A third, which accounts for about half of all participants, actually show that sort of quality, improvement across several of the attributes would likely improve engagement. And then actually, interestingly, a 4th class was dominated by people who very strongly preferred not to ever be contacted by phone or SMS, which shows that latent class can not only find, sort of strong positive preferences, but very strong negative preferences as too, and they can cluster in that way. So that will be a subsequent sort of manuscript, and I didn't share it here in the interest of time, but I have looked at it and it's very interesting. And I think generally people going into DCE should always approach their analyses with a latent class approach, because demographics tend not to be predictive of preferences.
Great. Thank you for that question and for that great answer. I think there's probably going to be a lot of questions, and I was going to move us on, but Monica has her hand raised, so we'll let her ask something brief, then we'll move on.
I actually just, since DCE is rising in prominence and seems like such an interesting implementation science methodology, are there comparisons between this technique and qualitative techniques to elicit preferences? Is there, or will you be the person who will do that comparison, because it's so novel?
Yeah, so great question. So I think like kind of a broader point that you're speaking to is just like, what is the rigor or the different methodologies available for like assessing preferences, like or preference-based research? I think the attractiveness of DCEs is that they are probably the best or most rigorous way to quantitate preferences compared to, say, just asking people how much you prefer one thing or another, or rank order or things like that. The problem with those methods is that when you ask something, what things are important to you, most people will say everything. And then you, how as a designer of an intervention or of an implementation strategy, how do you sort of understand what trade-offs people are willing to make? So that's the big advantage that DCE adds, is it not only lets you quantitate like what's the most important, but it gives you insight into what trade-offs people are willing to make in order to access these enhanced features. So that's what I was trying to demonstrate, such that people would both travel further and wait longer to get same-day testing results. And then you can look at sort of what proportion of the population might be, sort of predicted to behave in that way. But preference-based research is an open area, and I think that there's a great need to advance methodologies in that space.
Great. All right. Thank you for that. And I have a list of questions I'm going to follow up with you on separately. Like,
great.
One, for example, I'm not going to do it now because we don't have time, but like hypothetical things versus very concrete, 10 kilometers away from the clinic versus a friendlier atmosphere, and how you address those things, because they're very different concepts. Anyway, okay, so I am going to ask Andrew to remain at the virtual Zoom podium and transition to introducing our guest speaker. So Andrew, take it away again.
Great. So it is my absolute pleasure to introduce our guest speaker today, Dr. Michael Mugavero. And Dr. Mugavero is a tenured professor of medicine Oh, I lost my screen just like Mallory did. So he's a tenured professor of medicine in the Division of Infectious Diseases at the University of Alabama at Birmingham School of Medicine. So Dr. Mugavero earned his undergraduate degree at the University of Notre Dame before his completing his medical degree at Vanderbilt University. He then went on to complete his internal medicine residency at UAB, where he was also a chief resident. He then completed his infectious disease fellowship at Duke University while also earning a master's degree through their clinical research training program. And then Dr. Mugavero then joined the infectious disease faculty at UAB in 2006 as an assistant professor, and has since been promoted to full professor while publishing extensively in the field of HIV-related health services and outcomes research. So Dr. Mugavero is widely recognized as a national leader in the area of HIV care engagement, retention, and care. His research over the years has focused on evaluating the effects of clinical, behavioral, social, and epidemiological determinants on health behaviors and outcomes in persons living with HIV in the United States, especially those in the Deep South, which is an immense area of interest and need. So over the last 10 plus years, he has made seminal contributions and advancements to HIV prevention and treatment science, including conceptual models, measurement, monitoring, and other methodological considerations, as well as theory-informed intervention approaches and strategies to enhance engagement throughout the HIV care continuum. In addition to being a highly dedicated mentor, Dr. Mugavero also holds several critical leadership roles, including serving as the director of UAB's Center for Outcomes and Effectiveness Research. He's also the director of UAB's Training Academy for the Center for Clinical and Translational Sciences, and he's also the co-director of UAB's CFAR. So with all of that said, we are absolutely thrilled and honored to have Dr. Mugavero join us for January's CFAR seminar. And today he'll be telling us about the HIV epidemic in his home state of Alabama, and he'll highlight progress made and challenges that remain. And then we'll pivot towards talking about how the principles of ending the HIV epidemic can be applied to improve other major population health challenges. His talk today is entitled Ending HIV in Alabama, a Work in Progress. And please join me in welcoming Dr. Mugavero. Thank you so much for joining us today.
Great. No, thank you, Andrew, for your presentation and for the very kind introduction, and Mallory and Monica as well for the introduction and the invitation to be here. Really tremendous for me to be here. As folks were signing into the Zoom, just so many friends and colleagues. So thank you for inviting me. I'm sorry, it's supposed to be in April of last year. I wish I could have been there in person, and really can't wait to get back to San Francisco and see so many friends. It's so great to see so many of you on Zoom. So this is the title of my talk, and I think everyone can see my screen okay? Great. And so the outline, and Andrew, thank you for the overview. And again, for your talk is going to play in nicely to some of the research that I'll show. Going to start off with just the big picture in terms of EHE in the overview and origins. I think very familiar to everyone on this call, but want to go through that history and the 10-year kind of journey to get here, because I think it's very informative to where we're going in the future. We'll then pivot and talk about ending HIV in Alabama, work of our CFAR, a multidisciplinary collaborative team as a work in progress. And then want to focus on, is EHE globally a paradigm for population health? And we'll look at COVID-19 as a case study. So, thinking about some of the principles, some of the things that have informed EHE over a decade plus, how might those things apply to pop health for other non-communicable conditions, and really then look at the COVID-19 as a case study for that. So I think everyone on this call incredibly well versed in EHE, a plan for America, the very ambitious goals of reducing new infections by 75% by 2025 and 90% by 2030. The 4 pillars, again, well versed: diagnose, treat, prevent, respond. I think one of the key aspects of EHE has been this interagency coordination and collaboration at HHS. So between NIH, Indian Health Service, CDC, HRSA, SAMHSA, from the outset, being on the same page, working from the same playbook in really a coordinated manner. And after this initiative was announced, the State of the Union address, in a very coordinated way the following day, in JAMA, an editorial with leaders from multiple agencies at HHS for the scientific community, outlining EHE, outlining the plan and what it was. And then just a month later at the prevention conference, I had the honor of being a co-chair, a scientific co-chair of this conference. HHS, every agency, including the secretary, was represented and very consistent in the messaging about EHE. So the communication, the coordination, the messaging across every agency from HHS, incredibly consistent from the outset. But I think we have to look at this and say, there's a long history that led us to this moment. So going back to me on the origins, and it can go back even earlier, but formally, how pivotal the inaugural National HIV/AIDS Strategy was, released in July of 2010. ONAP Director Jeff Crowley, with significant contributions from Greg Millett, putting this document out there, doing a lot of elicitation, and focusing for the first time a national strategy, a national plan to address HIV in the United States, with 4 principal tenets to reduce new infections, increase access to care and outcomes, reduce disparities. And the 4th one actually got less attention, was to achieve a more coordinated national response. So the idea of better coordination, better collaboration across agencies at the federal level, but also at the ground in local jurisdictions and local communities. So shortly thereafter, I think everyone well aware, Ed Gardner and colleagues published the treatment cascade for the first time. And I think what was remarkable to me was people like Chinazo Cunningham, Tom Giordano, others had written these numbers in manuscripts for years. But this image, the idea that a picture being worth 1,000 words, this image really kind of unified the scientific, the policy, the advocacy communities around the challenges faced on this cascade. So at CROI, I remember this year, Carlos Del Rio, who was the senior author, alluded to this. And many of us go to the adherence conference every year, and this was on every single slide. All the rage was the treatment cascade, and highlighting at the time the real challenges in terms of, while we had effective therapies, effective treatments, the real challenges was, that 20 to 30% of persons living with HIV were undiagnosed, and fully half of persons that were diagnosed with HIV were not engaged in regular medical care. So the real challenges to achieving the full promise and potential of treatment advances lied in access to care, testing services as the way forward. So if we fast forward, update in terms of transmissions across the care continuum, I think a good bit of progress has been made. So in the most recent estimates from the CDC, reductions to now estimated 15% of persons living with HIV not being aware of their status, but accounting for 38% of new transmissions, substantial improvements in care engagement. So estimates of 23% of persons who were living with HIV and aware, but were not in care, but again, accounting for a large number of the new cases, so 43%. I think pivotally in the bottom row, the 51% of persons living with HIV in care on medications and suppressed, accounting for 0 new transmissions. So clearly progress along the care continuum, clearly work to be done in testing and care engagement. And I think on the next slide, just highlight U equals U and just how powerful that campaign has been. I think everyone well aware from the Percent Prevention Access Group and community advocacy and strong community voice, and empowering folks living with HIV, and just how important this message was. And I think to pause and acknowledge, John O. Merman and Eugene McCrae, their Dear Provider letter that was September 27, 2017, essentially saying persons living with HIV who have a suppressed viral load cannot sexually transmit the virus, and just how powerful and affirming that was. And then in short order, a number of states and local health departments, endorsing and acknowledging U equals U, and just how powerful that message has been, and how important that message has been, and the vital role, as all of us know from the outset, of community, of activism, of engagement, and really advancing our collective efforts towards effectively addressing HIV in the country. So again, this is a very abbreviated timeline of kind of the 10 years leading up to EHE. And in the interim, after Jeff stepped down, Grant Colfax was the ONAP director. And in his tenure, key was really the HIV Care Continuum Initiative. And then in the next phases, as Doug Brooks and colleagues were planning to update the strategy, in 2015, some major advances. And again, didn't show the primary data, I think all well versed, but the idea of first with IPREX and then other trials, our prevention toolkit now, with PrEP, an evidence-based intervention for prevention, dramatically advancing our toolkit. With HPTN 052 confirming, over a decade of observational studies and definitively showing treatment as prevention, really having the evidence in terms of PrEP and TASP as being effective tools. the Affordable Care Act, how that transformed healthcare in many places, unfortunately not where I live, in many other southern states, but the impact of the ACA, changes in testing recommendations and the care coordinator and new research. So a lot of iterative progress from the initial strategy, focus on the treatment cascade, new tools leading to the updated national strategy and Doug Brooks with President Obama. And I will say, in thinking about the coordination and consistency of a plan, to Doug's credit, I think similarly did listening sessions, talked with folks, and decided, even though this was new for him to update this, the vision from the original strategy hadn't changed. So I think maintained that vision and said the vision that was articulated is still the right vision. So consistency with the updated strategy and thinking about where we're going. And I think in focusing on the right people, right places, and right practices in that updated strategy, also kind of highlighted what are the tools and focused on widespread testing and linkage to care, full access to PrEP, broad support of persons living with HIV, and universal viral suppression. So I think if we even think about where we are now with EHE, really the same three pillars. I mean, the idea of diagnose with testing, prevent, with PrEP and other services, treat in terms of the power of viral suppression and U equals U, and then the new EHE also including respond. But over 10 years, the messaging, the strategy, the focus has really been consistent in terms of how from a policy level and a high level do we aspire to effectively address the HIV epidemic in the US. I think very powerful. The first time I saw this was Dimitri Daskalaskis, who will now be the head of DHAP, which I think is incredibly encouraging at CDC. Present this at the adherence conference, others as well. Hyman Scott kindly shared this slide. But I think the status neutral continuum, the same way the original with Ed Gardner and others treatment cascade, thinking about this in terms of more fluidity, in terms of testing being a gateway, and then a continuum of treatment and a continuum of prevention, very powerful. I think historically, a lot of times there was prevention was in one camp and the CDC did that and treatment was over here and HRSA did that. And so the idea of thinking about HIV testing, prevention, and treatment more fluidly across this continuum, how different agencies and HHS and other would engage in service delivery, very powerful to think more holistically about an approach to addressing HIV in the US. And then, constitute on this status neutral continuum, these four different pillars from the updated 2020 strategy. And again, that aligned very well with the EHE strategy and the four pillars there. So a few reports that came out towards the end of last year from CDC, looking at progress since 2010 and updates. I think modest improvements in terms of viral suppression. So from 2010 to 2015, about a 10% improvement in viral suppression, modest reductions in new cases, about a 15% reduction from 2010 to 2016. I think the report on the right side got a lot of attention towards the end of last year. And so that while maybe more modest improvements in viral suppression and reductions in new cases, really dramatic improvements in declines in mortality and especially HIV-related deaths between 2010 and 2018. And I think something to celebrate, and clearly iterative progress, how much we attribute to the strategy and other things. But again, seeing this progress and this success, something I think all of us celebrated, we're happy to see. And hopefully we'll see similar improvements and more dramatic improvements in terms of care engagement, viral suppression, and reductions in cases in the decade ahead. So kind of seeing where we are now, with these ambitious goals, and who knows what comes next with the new administration, new leadership at CDC in terms of where we go. But these same pillars, even if they're repackaged, look very similar to previous national plans and where we're going. And clearly, I think in testing, we're much closer to our targets, have a ways to go in terms of prevention and PrEP delivery and uptake and implementation. And also in treatment, have improved rates of viral suppression substantially, but really still have a ways to go to fully achieve the promise and population health benefits of treatment as prevention and U equals U. So thank you for indulging that kind of 10-year journey. I think, again, familiar to all of us, but grounding for me to go through that history and figure out, where we are now and how we got to this point in time. And we'll now go through a similar kind of 10-year journey on the experiences in Alabama and at UAB. And again, the history is much longer. It goes on for 30 years, but in a more abbreviated time frame, we'll share some of the work that we've done collaboratively to get to where we are with our CFAR and community and public health partners towards ending HIV in Alabama. So I go back to 2010, and there was a HRSA SPINS, a special project of national significance that we applied for Birmingham Unite. And so one of my jobs is to make the acronyms. Most of them are terrible. I actually thought this acronym was pretty good. So this was going to be a unified network to integrate testing and engagement. And so we looked across Birmingham and said there's the JCDH, the Jefferson County Department of Health. There's our UAB 1917 clinic, so named because of our original street address of 1917 Fifth Avenue South. St. George's, another Ryan White clinic with our county hospital. The Family Clinic, a Part D clinic, and then two key community partners, AIDS Alabama and BAO, ASO, CBOs, with the client at the center. And the idea for our HRSA SPINS project was a health information exchange, so that we were all reporting client level data about services to HRSA and to CDC, but all that data sat on servers in Atlanta or in Bethesda and didn't feed back to service delivery on the ground. So, a concrete example, someone who I'm their medical provider have not seen in over 12 months time, but regularly going to BAO to receive services, whether it's, food supplements, housing services, other services. So the idea with the client at the center, could we integrate information about service delivery to identify gaps in care continuum and look to better provide services for, integrated care. So this was not funded. This was not funded, and I think is a great example of, from failure can come success longer term. Having these conversations set a foundation for us for the future and how we wanted to do things as a community and do things differently. So actually I think it was November or December of 2012, I was out in San Francisco. Project Inform had done a think tank around using surveillance for programmatic purposes. And at that meeting, Callie Lindsay, who at the time was with the NMAC, the National Minority AIDS Council, talked about doing a community dialogue. And we organized this with NMAC and Callie's help in January of 2013. So a few years after that unsuccessful Birmingham Unite grant. And at the end of the meeting, it was a great dialogue, a great discussion. One of our community partners said, as an action plan, how about Unite? We had that idea, it wasn't funded, but we have to make Unite a reality. And also the idea of everyone else has a cascade. Where's our cascade? So out of this meeting and dialogue came an action plan of we need to make Unite a reality. And really with our public health partners, we're 2 years after these national cascades in many states and local jurisdictions, we need a cascade. So shortly thereafter, with our Department of Public Health, the first Alabama treatment cascade in 2014, equally challenging, very consistent to other places in the country in terms of where the gaps were and where the challenges and opportunities were. And then Birmingham Unite became manifest in this group that was called the Jefferson County HIV/AIDS Community Coalition. So this group met for the first time in March of 2013. So 2 months after that community dialogue. This is a picture from a few years later when we talked about data to care with our public health partners. But we came together and it was representatives from each of the clinics, each of the community-based organizations, the local health department, the state health department, and 5 consumers, persons living with or affected by HIV, and came together and said, we need to have a more coordinated approach and a more coordinated plan. Up to this point, it had been people coming, asking for letters of support, last minute, those kind of things. Was at a foundation, we need to have a shared set of goals and platform that we can come back to as opportunities emerge to guide us going forward. So from that, we formed, this coalition, officers, after the first meeting, didn't know, but folks were very enthusiastic about meeting, and we've met every month since this time. But the goals were broad: to improve outcomes, enhance prevention, treatment, and research opportunities, improve social economic justice, foster community collaboration, and look for long-term sustainability with all the partners there. Critically, this was not a mandate. This was not some funding agency sponsor saying we had to do this. This was not something that a grant required us to do. This was, I think, as members in the different agencies saying, we need to do things differently if we expect different results. And so from this coalition and coalition building, you know, a lot of goodwill. And the first opportunity that came up that really threatened and challenged us was when the CDC put out PS 15-1502. And this was a funding announcement for high impact prevention programs for CBOs, for community-based organizations. And in CDC's wisdom, they said if a single agency goes in for this grant, the max direct costs were $450K a year. A coalition of agencies could get $850 a year. So I think, you know, initially saw this and said, this is fantastic. We've been meeting for 2 years. We've got a lot of goodwill. We have a shared platform. We're in great shape to go ahead and apply for this. So it was interesting. The coalition up to this point had largely been prevention directors of agencies, you know, similar type positions. So now all of a sudden, when faced with the first funding opportunity, it was the executive directors coming around the table and talking about this. And, you know, it went to who's going to be the lead agency, if we want to do it collaboratively, or we're going to go alone and we can't do it together. So things were kind of going south in terms of the discussion, because I think a lot of interest in, you know, who is going to lead and how can we do this. And really thought, you know, after 2 years of goodwill, when faced with the first challenge, this is how the coalition falls. And it was really powerful, and I can't do it justice, but a consumer, someone living with HIV at that moment, spoke up and said, you know, for the last 2 years, you know, I thought we were different. I had heard heretofore about how all these agencies were all about the money and that's what mattered. And I thought we were different, and we're not. And at that moment, you know, pin drop silence, and the tenor of this discussion changed, and it went towards how are we going to do this together? The smallest of the CBOs went in as the lead agency. Everyone else got behind it, and resources were shared. And this went in and was funded and really helped change the course of how we approached collaborative HIV prevention programming in Birmingham. A few years later, we were able to help the health department apply for CDC 15-1509 to further expand resources. And I would say, you know, it was challenging, but if we had not had 2 years of discussions and community building and talking about things, there's no way we would have been able to come together and come around moving forward for that BCHIP grant. And we'd be back where we were, where every agency was kind of more independent, collaborative, cordial, but last minute letters of request and not nearly as collaborative or coordinated in our response. So Birmingham Unite in 2021, a lot of new partners. We have a universal release that allows for information sharing with permission of clients across agencies. That's allowed for better tracking. We do not have a health information exchange, are not resourced to do that. You know, better integration and, you know, data-wise, a 25% reduction in new HIV cases in Jefferson County, where Birmingham is, over this time period, while during the same time period, number of new cases in the state have been flat. And again, can't say there's causality here, but reason to believe the efforts, these 2 large grants from CDC really helped increase resources, leading to improvements and reductions in new cases in Birmingham, while the rest of the state remained flat. So looking now where we are, you know, we have a scientific working group ending HIV in Alabama. We've situated ourselves on this status neutral continuum, you know, a broad portfolio of projects, a broad portfolio of research. Cannot go into the details about all of them, but very orienting, very grounding for us as a CFAR and a scientific working group to be situated around this status neutral continuum, looking at these pillars and how we organize ourselves, how we collaborate within UAB and outside of UAB. And Jeannie Marazzo and Adi Arana co-lead this group, and it's been just tremendous what this SWIG has done to organize investigators at our CFAR and at our institution. So, you know, just to give a sense, a big picture again, PREVENT, there's a lot of community engaged PrEP research going on, a number of different individuals. Just wanted to share to give a sense of just how, you know, robust this program was and what's going on. Need to thank Andrew. I wanted to just take a deeper dive. So this is Letitia Alopre. So she's an early career faculty member, early stage investigator who's currently supported by an NIMH K23, as well as a Harold Amos Award from the Robert Wood Johnson Foundation. And Andrew, you beautifully set me up to talk about her work using a discrete choice experiment to understand PrEP preferences among African-American women in both rural and urban Alabama. And this was done with our community partner, Medical Advocacy and Outreach in the southern part of our state, you know, where there's a high, you know, incidence and high prevalence of HIV. And Letitia, through her discrete choice experiment, found the attributes that women really prioritized were, in terms of healthcare facility, wanting to receive PrEP services in a provider's office. And so just to orient, the red bars are folks who said, I would not be interested. The green bars are women who said, I'd be open to. And the blue bars were women who said, I would be, I would want PrEP if made available to me. And what we heard from the women in Letitia's study was, wanted to be in a provider's office, do not want pharmacy-based services, do not want in an STD clinic. And then moreover, what we heard in terms of the how to receive the formulation, a long-acting shot or a pill were preferable, did not want implant, did not want vaginal ring. Don't have the time to go into the details, but similar to the earlier question, did latent class analysis looking at kind of different groups. And this has really helped Letitia to inform some of her work in Next Grants, looking at different strategies to deploy PrEP for African-American women who I think everyone knows, very low uptake of PrEP nationally, also in Alabama, but really has been critical to advancing her work in Next Grants and trying to increase PrEP implementation in this group. So the next thing we're just going to share is some of the work we've done around diagnose, test and treat, and time to viral suppression. So several years ago, had a chance to reach out to Irene Hall, who leads epidemiology and surveillance at CDC, and talk about, we have diagnosis and this treatment cascade or treatment continuum, but that CDC uniquely has the data through EHARs on both testing dates and viral loads being reported. Can we look at the anchoring points of diagnosis and first viral suppression to evaluate not each step on the continuum, but the overall performance that might speak to a jurisdiction, both the clinics, the health departments, and the community agencies working together and helping folks move from becoming aware that they're living with HIV to achieving suppression. So at the time, there were 19 jurisdictions. What we found was the median time to suppression was 19 months. So a year and a half. This was 2009 data. It took a year and a half from someone learning of their HIV diagnosis to achieving a first viral suppression. Among those who were linked to care in 3 months, it was 12 months, so it was better. And among folks with more advanced infection, 8 months, median time to suppression. And in this paper, we talked about time from diagnosis to suppression being a novel metric that really spans the anchoring points on the continuum and really could help guide and orient efforts at a jurisdiction level. So Scott Beatty, who's a colleague in social work, led this next project working with the Alabama Department of Public Health, looking at temporal and geographic trends in time from diagnosis to viral suppression in Alabama. And the first thing that we noted, and again, so going back to the national data in 2009, 18-month median, that between 2012 and 2014, substantial improvement in the median time from diagnosis to suppression. So from 10 months down to 6 months. So really substantial improvement in temporal trends. This is the state divided into the different public health service areas. What was also really striking beyond the temporal improvement was just how dramatic the geographic variability was. So public health areas 3, 4, and 5. So 4 is Jefferson County, Birmingham, but across that band in the northern part of the state, as short as 7 months or as long as 13 months in terms of the median time to suppression. Similarly, in the southern part of the state, areas 9, 10, 11, as short as 6 months and as long as 13 months. So really begged the question of, in a relatively small state with a modest number of new cases, 700 cases a year, why is there so much heterogeneity? What is driving the variability in the time from diagnosis to suppression? And can we learn more about this to inform public health interventions to improve timely and sustained suppression? So that was the foundation for an R01 led by Adia Rana and Scott Beatty as MPIs, collaborating with not only the Alabama Department of Health, but also the Louisiana and Mississippi Departments of Health, and looking at quantitative analyses, time from diagnosis to suppression, including also GIS, qualitative in-depth interviews with local stakeholders to really try to better understand why are some of the areas that are having more success and more timely suppression versus longer, what are the key ingredients to help really inform public health clinical community rapid ART prototypes. And just some of the data from Adia and team, this is looking at median time to suppression among the different public health areas in the 3 states from 2012 to 2015. The darker green shading is a median of 270 days or more. and the lighter shading is shorter time. So this is 2012 to 2015. If we fast forward to 2018 to 2019, dramatic improvements across all 3 states, most notably in Louisiana. Noteworthy, Louisiana, the only of the 3 states to expand Medicaid, but really dramatic improvements. And this work is going forward now with some of the GIS work and interviews to help inform rapid art prototypes for in the Deep South. So the next thing I was going to talk about, it's impossible for me to not talk about missed visits. This is a study that I did in 2009. I think probably will be one of my most important, if not most important contributions, a really simple study looking at 543 persons newly entering care at our clinic. And what we found was that persons who missed a visit in their first year had a 3-fold increased mortality risk. And that was comparable to a CD4 count of less than 200 on care entry, older age also associated with increased mortality. And the take-home message from this study to our providers, our social workers, our nurses was, this early missed visit is not necessarily causally responsible for the higher increase in mortality, but what a powerful marker. So when we're seeing someone in care and they're missing a visit, they're telling us whether it's around their context, competing demands, social, structural determinants, discrimination they're facing. This is someone who's at higher risk of long-term mortality. So this missed visit is a really powerful indicator for us to identify folks that need more attention to understand why might they be at greater risk to not do well longer term managing their HIV infection. And subsequently, a number of other studies showing that missed care visits associated with delayed ART initiation, poor retention, prolonged time to suppression, disparities, mortality, hospitalization. A student did a systematic review, kind of really showing this very consistent dose-response relationship. And my message to clinics and clinicians is one of, uniquely in clinics, we capture data about visits. Most public health and health departments don't have this data. So a really powerful indicator for us in the clinical care settings to identify persons who might need greater attention and outreach. The next step for us, this was through a quality group that exists, a statewide consortium of Ryan White clinics. The stars indicate the clinics themselves. The circles indicate either telehealth or satellite sites. This group has existed for a long time, led by Ashley Tarrant and Jitesh Parmar at 2 of our CBO partners. And our next step was to do this Data for Care program. So it's a spinoff of Data to Care, where we are doing clinic-wide risk stratification based upon missed visits to identify persons to receive their attention through enhanced personal contact evidence-based intervention. So the first thing to point out is, this is now getting client-level data with informed consent and approvals from over 8,300 persons living with HIV in the state. So essentially a statewide clinical cohort that really is a powerful research tool. And then stratified in terms of the number of missed visits in the previous year. 0 was in 51%, 35% 1 to 2, 3 or more was 14%. But then this risk stratification led to how we would deploy the intervention. So folks who were low risk, half the clinic population, no intervention, intermediate and high risk get the retention through enhanced personal contact intervention. So I'm going to close just briefly with this idea of, EHE, this 10-year journey to get to this point. Is this a paradigm for pop health? So I recently had a chance to talk at Grand Rounds at Wisconsin and really thought about, are there lessons learned around EHE that could apply to other chronic diseases, be it diabetes, hypertension, and then looking at COVID-19 as a case study. And so when I looked at EHE as a paradigm, I think some of the key things to me that have been critical pieces, the federal government prioritization, having a national plan since 2010 and pretty good consistency across the pillars and what that plan looks like. It hasn't changed very much. The degree of interagency coordination and collaboration across HHS, I think, is unique. The idea of data-driven clinical and public health program delivery. So I think we're in very privileged space with data through EHARs and reporting, but is there similar data reporting? All the discussions around the ethics and individual privacy, but having access to near real-time data to inform program delivery and iterative evaluation, incredibly powerful. This idea of a status neutral framework with testing as a gateway and then prevention and treatment really I don't think is unique to HIV. The idea that there's a robust research infrastructure. So we have this through the CFARs, from the AIDS research centers, through NIMH like CAPS, and targeted funding opportunities aligned with this EHE plan, funding that has to be oriented to the strategy, and on the ground, the local triangulation of community and clinical and public health partners. So when I looked at the case study of COVID-19, I think really would say have failed miserably in terms of the prioritization, planning consistency. There really has not been, by my take, the coordination and collaboration across agencies of HHS that we have seen for ending HIV. Having said that, the data that we have around COVID is unprecedented. I mean, the real-time data dashboards is unreal. And so I think some of the things have been applied and been very effective. So the idea, again, the data and data infrastructure to kind of monitor, track, and inform intervention is outstanding. And really, I hope that some of the lessons in COVID data will inform our HIV and other kind of data reporting. We are operating with lags of months in terms of the data reporting to inform action. So if a silver lining for me is, might the improvements in data systems for COVID reporting translate, would be a big win for our efforts. In terms of the idea of a robust research structure and targeted funding, so I think probably folks are familiar with the RADx program. So NIH, led by Director Collins, leading this program of rapid acceleration of diagnostics, including this $1.5 billion program, and the RADx up of this idea of community engaged projects for testing. And I think smartly, NIH saying you have to be supplements to existing centers that have the infrastructure, have the capacity. So aligning this research infrastructure with targeted funding around goals for COVID testing. We were fortunate through our CFAR to get one of these supplements. And if not for the 10-year journey building community, building collaborations around EHE, there's no way we could have applied for this supplement and received this funding. But our project is community engaged testing in Alabama. It's 2 years of funding working statewide in rural communities, trying to more than double testing in these counties, going to go into 3 counties in 6-month waves, in 2 successive waves, doing 1,000 tests a month, grounded in the ADAPT framework of assessment, prepare, implementation. And beyond increasing local capacity with test kits and PPE and personnel, our 3 active ingredients are peer health advocates, community health workers, and venue-based testing. So to give a sense about data-driven programming and strategy, Lynn Matthews with a team of epidemiologists doing some data-driven work, looking at a number of different markers, and came up with a strategy of 3 different approaches to prioritize our counties for intervention. And where we're starting is in Franklin County, Clay County, and Clark, so different areas of the state that really hit upon some of the metrics in terms of where the greatest need is. So, data-driven population health, I think, as we all do, being foundational to the work that we're doing with this project. We'll kind of go through this and just share big picture. The assessment, preparation, implementation phase, again, going to the local triangulation, assessment being identifying our counties, using an algorithm to select. Preparation, we are now doing in-depth interviews and surveys with folks in the 3 counties, and then going to deploy with our community partners, venue-based testing with community health workers, peer health advocates for education, for outreach. And then we'll have the information from our first wave inform our second wave. And again, but for the 10 years of work of the CFAR, lots and lots of people, several I've mentioned, many I haven't had a chance to mention, there's no way we could do this work in doing the outreach and trying to look at a pop health approach to COVID testing that will inform our vaccine efforts in a state like Alabama. And with that, just a lot of folks go into doing this work. So this is our team at UAB for COVID COMET, community partners, human subjects, scientific advisory board, can't name all these folks, but want to acknowledge them. And then again, for the ending HIV in Alabama, I love pictures. And so these are some of the different groups, our frontline providers who we've engaged, our quality group, and our group at the CFAR with the mayor signing on to be a fast track city. And all these community agencies, all the community organizations. So with that, I will stop. I think I saw some things pop up in the chat I couldn't read, but I think maybe a few minutes for questions. And again, want to thank you for the invitation, Andrew, for your presentation and the introduction, and just the opportunity to be here with you this morning.
huge amount of content, and thank you so much for that. I think you triggered a lot of questions, which I will jump into. So there were two people got jumped in line first here in the chat. So let's hear Natalie Wilson, and then Susan Kegelis has a question as well. So Natalie.
Yeah, thank you. I started to call you Mug, sorry. Dr. Mugavera, that was a great talk. And it's good to see you. So I had a question. When I left Alabama, there were like 54 of the 67 counties were still rural, and 2 to 3 of those counties had a primary care shortage of providers. So I'm wondering if there's an association in the variability in time to virologic suppression with this shortage or distance to provider?
Yeah, no, I think Natalie, it's a great question. And I think we haven't gotten to the point of looking at those kind of indices, but important to think about and just eyeballing it. And your point is well taken. Some of the areas that are doing well are areas where there is robust, if not providers, telehealth programs. So MAO is in Montgomery, but broad telehealth reach. And just eyeballing some of the areas that are doing well are areas where MAO is clearly there. So I think don't have formal evidence, but informally think there's reasons to suggest what you're talking about with provider availability being associated, possibly being a contributor to that variability. It's a great question.
Yeah, thank you.
Great, thank you. Susan, did you want to ask yours?
Sure. Hi, Muggs.
Hey,
Dr. Mukavero.
Mugs.
Muggs. I've done some work in Texas for a number of years, and I'm assuming a lot of the issues we find there are similar to Alabama. And specifically, there's so much concern about, on the part of patients, about being treated well if they're MSM or if they're trans, feeling that the providers just aren't sensitive to the issues that they face and can actually embarrass them, ridicule them, shame them, sometimes inadvertently. And then there's the constant concern about racism and am I being treated appropriately? Are people acting towards me in a certain way, and so forth. So do you address those in your collaboration? Have there been attempts to get at those issues?
Yeah, it's a great question. And I think both of those are clearly factors that are very real and present. And there are things that do come up through these collaborations and through both discussion, through trainings. I think, Susan, what we see is with a lot of the community partners and agencies that are doing this work, a lot of attention and addressing those considerations. I think where we see a lot of challenges is outside of this workforce and community and agencies. But how do we do work with the broader population of service providers and trainings is front and center, and I think very critical. So absolutely, those observations translate, I think, are very real and are part of the broader portfolio in terms of addressing not only in the HIV prevention, testing, treatment provider community, but more broadly, because a lot of the intersection, is outside of our, provider community where oftentimes there are those experiences that really make things incredibly challenging.
Okay, thank you.
Great. I know that Monica had a question in the chat, and we're closing in on the end of the hour. Monica, did you want to?
I'll just be fast because Mike, a lot of things. Do you think that the EHE program will continue with the new DHHS? And second, the CDC HRSA money has been more. There's been more funneled towards those organizations, which you're very well aware of. But do you think the NIH will get more money from and the HIV Epidemic Initiative, not through the CFARs, but through R01s and other?
Yeah, Monica, I think it's a great question. I don't have any insight. I mean, like in terms of
I thought you'd have inside knowledge.
No, I have had no direct conversations. You know what I mean? Like, and I guess for me, and especially knowing, with Rochelle and Dimitri and some of the folks, I mean, and again, whether it's EHE and the 4 pillars there versus how Jeff and Greg, I mean, I feel like it's the same pieces. We know what the pieces are. So however it's structured or situated, I imagine it's consistent. The question about resources, and not just targeted resources through the CFARs and ARCs, but more broadly R01, I would hope so, but I just have no insight and kind of to have any definitive answers more than I think others on the call and that UCSF might have.
Thank you.
Great. All right, I think we are at our hour, and if this were any non-COVID time, we'd have the whole day with Muggs, and we'd have a meet with our early career investigator. We would have a whole bunch of things. So I am going to offer on his part, and also Andrew Kirchhoff, that if you have questions, I know both of them would be open and receptive to your emailing them or calling them and setting up a time to interact, because it's stimulated a lot of interest, and we just don't have the time today to continue it. But I want to thank both Dr. Magavero and Dr. Kirchhoff for their contributions today, and this was fantastic. Thank you both.
Thank
Awesome.
you.
Thanks for having me. Really appreciate it. Can't wait to get back there. Andrew, I very much look forward to meeting you. Really learn more about your work.
Absolute pleasure. Thanks for joining us today, and thanks to everyone.
Great. Okay. I believe we're transitioning to our internal advisory board. So those of you take a quick stretch break, and we'll see you.
Yeah, just stay on the line if you're on the IAB, right? So thank you.
Take care. Bye. Good to see everybody.
Thank you, Michael. Thank you. We'll just wait a few minutes because
I'll just start removing people.
couple people who are, I think, going to disconnect.
Okay. What happened here? Oh, there we go.
I think that.
They could be looking elsewhere, but I think everyone did. Okay, yes. Okay, we have a lot to do, so we'll actually just go right in. And the agenda, thank you very much for being at this IAB meeting, which is every other month after the seminar. And that was a great seminar. That was really interesting. So every other month, we will give you updates in the IAB, but we actually mostly have things where we need to elicit your input. And we sent the agenda yesterday. We're just going to give you a quick update on the CFAR awards that just got funded, the developmental awards. But then we have lots of questions for you and items for discussion. So really want your frank, the safe space, frank input on some of the concept sheets that you kindly reviewed, anything that that you're comfortable sharing with the IAB, and also really want to discuss with you a possibility of leadership in the CFAR that, with full disclosure that diversity, inclusion, and equity has not been represented as much in our very high CFAR leadership. And really want to talk to you about this. And then the final thing for today is that we had to choose the external advisory board, and we have great EAB members, but always it's good to rotate some off and your ideas about bringing some people in. And we really need to invite those members. So this is going to, all of these 5 items on the bottom are going to require your input. So if you wouldn't mind, please be very vociferous today. Okay, so these are the 4 CFAR awards that just got, just got awarded. So one is to Emma Bainbridge, who's here in the Division of HIV, ID, and Global Medicine. And this is a pilot study of, with Annie Lukemeyer, essentially looking at antibiotic resistance with mycoplasma. And so that will be very interesting and important for these post kind of PEP, these doxy-PEP type of strategies. The second is from Amelia Diekman through Tim Henrik, but she's in clinical pharmacy. And we all know about Tim Henrik's really interesting targeting viral reservoirs through PET. And so she'll be looking at that more with this relatively smaller grant. And then the third is with Mallory Johnson as primary mentor, and Orlando is in the School of Nursing, as you know, and this is really to look at the time right now during COVID-19 to access with Latino and Black African-American sexual minority men in treatment and prevention. And then the last one is an international scholar who is working on insulin kinetics in people with dolutegravir in Uganda. So these were great. Thank you so much for reviewing, anyone who's on a review board. And too much to go over the Boost Awards, but I do have to say we have not got as many Boost applications again as we'd expect. So I would keep on encouraging your divisions and groups that you represent to be putting in for Boost Awards. Lauren, when is the next Boost Award deadline? February
Second
9th?
Wednesday of February.
And with Diane as ARI director, it's both a ARI and a CFAR initiative, of course, so you can do non-federal grants as well. I don't know, Diane, if you want to say anything about Boost. They're just so good. I mean, they're small, but easy to get. Okay, so this is what this vision is looking like so far that you guys have all seen by now. And what has changed since the last time we looked at it together as a group is that we haven't yet settled on leadership for the clinical core. We need your input about that today. And you all have reviewed now and will have opinions on each of these 9 domains within the 3 cores. And the other thing that's changed is that we need your input on 3 things today, not only the core directors, what you've thought of the concept sheets that came in, but also this idea if we should choose leadership or put out call for leadership for 3 of the 3 cross-cutting areas. That is something that Margarita and I had discussed when we talked once, and I would love to hear everyone's input. So let's start with the input on the core, the subcore concepts. I would actually just ask for volunteers that you've all looked, every single one of you did your assignments in time. Thank you so much. And especially since it was the holiday, we super appreciate it. And you gave high level reviews. I actually just wanted to call for anyone to give commentary on what you thought. We did read the reviews, but if you could share with the group your thoughts on any of these components. You can see the assignments and each of you did this and we so appreciate it. So anyone want to start with their kind of high level thoughts for each of the components so that we can discuss?
I can start.
Please.
So I did the substance use, what is it, subcore, I guess it's called.
Yeah, that's another decision to be made today. What do we call these 9 things?
I thought it was really well conceptualized. It was highly significant, really tied to goals around equity and so the cross-cutting themes. So including the one around community engagement and health disparities. I think the leadership team looked great. I think the ideas around what they outlined about what they would be doing made a lot of sense. If we're going to get to the end of the HIV epidemic, we have to really be thinking about substance use. And that was one of the things that we were dinged on our CAPS proposal, is that we didn't have substance use included.
You already got your reviews.
So
and, yeah.
We got our reviews, and that was one of the things that came up. So I thought I thought it was really excellent.
And we really do have the expertise, as you noticed, by the leadership at this university. So that's great. Thank you so much for that glowing review. I think I'm also really excited about the substance use component and that it doesn't overlap currently with too much in CAPS, which is going to be a criticism. And luckily, we had talked about that before. Anyone else want to chime in for any of their reviews?
Yeah, Monica, I'm just going to chime in quickly because
Please.
I also reviewed the substance use, and I think I just agree with everything that Margarita already outlined. I thought that it was really well conceptualized and described, and again, like addressed multiple cross-cutting areas.
Lillian, thank you.
Yeah, I want to echo that too. I reviewed the immunology and the pharmacology. I think both excellently conceptualized and put together. I just wanted to say that I find immunology is such a staple of what we do and such an important part of the HIV biology that it is a no-brainer for me to say that we absolutely need it. I think the key issue here is to find a good new director, and I think that search is underway, and I think will be critical to get somebody somebody in there. I thought I was very impressed with the pharmacology core, because I think it's very state of the art, and I just thought that it's probably going to be a little less used than the immunology core, but in general also an excellent team, and very, very nice focus also on AZ, promotion and mentoring, which I thought was a big positive of that application. Very impressive.
I want to give kudos to Peter. Peter, you really put the immunology core together. So thank you so much. I mean,
yeah, happy to step in.
No, it's great, and I think I'm glad to see Jane involved from Gladstone, because I think she's really excellent, and somebody, and I'm really glad that Gladstone is involved here. But I just think it's such an important part of CFAR that we really have to make sure that it continues. And thank you for stepping up and revamping it.
Sure, and Jane is terrific too, and so we look forward to continue to work together.
Peter, is that an active, ongoing search?
So Joel has secured approval for the exception to the hiring freeze for both a non-faculty and a faculty search. We already have several candidates that have expressed interest. Some of whom are I know very well, who are exceptional. So I think that we're going to be in good shape. I'm confident in that. So
maybe even before the renewal.
Oh yeah.
Okay.
I'm pretty confident in that. Yeah.
I think it would be good if we had somebody in there before the renewal. I think
absolutely.
It would be even stronger.
I mean, they may not physically, humanly come, but hired before the renewal, so we could get their input.
But it's definitely possible.
Okay.
Monica, I'll add to what Melanie said. So my comments were, I think, almost identical to what Melanie said. It really is the immunology core is like the engine of our kind of human translational immunology program here, allowing us to go from bedside to bench. And the one thing that I like was beyond kind of continuing the services to our community, the fact that they're adding in 10x capacities to do single cell RNA sequencing, and also that new Cytek Aurora. We actually just got one of those at Vitalant also, which allows like 40 parameter flow cytometry. Those will, kick everything up a notch even, which I think is awesome. I guess since we talked about that, I can also talk about the bioinformatics core. Some of these new high dimensional capacities that are being proposed for the immunology core would synergize really nicely with the capacities that are being developed by the bioinformatics core. So I think there's like a kind of a natural interaction between those two cores. And I thought the bioinformatics core as proposed was awesome too. It fulfills an essential niche here, because I think there's a lot of high dimensional data that's generated that doesn't see the light of day, because a lot of independent groups don't have like a bioinformatics team built in to process a lot of those data. And I also like the fact that the ImmunoX CoLab resources are being leveraged. So there's kind of a lateral commitment there. So I thought both the bioinformatics and the immunology core were extremely promising. So one quick question in terms of like how these were reviewed, can all of these cores go forward in the recompetition, or do some of these have to be selected at the cost of others?
You're muted, Monica.
They're all going to go forward. That was actually part of the process of approval. And we ran them by you as well. When we even designed this figure, we talked about this. So they're all going forward. It was just that, could you as reviewers improve them or make suggestions, so that when we actually put the text together, we ask each subcore leader to say, okay, yeah, you should have thought of this and you should have thought of this. But they're all going forward.
Yeah. So the only one additional comment I'd make about the bioinformatics core is I think it's a real strength that they're tapping into a existing infrastructure and a lateral investment from the ImmunoX program. The only one potential danger there is that there are probably a lot of ImmunoX faculty that are already aggressively tapping into that resource. So I think we need to be a little bit vigilant to make sure that the HIV/AIDS investigators that are CFAR are getting efficient access to the bioinformatics core resources, or at least proportional access to the resources offered by the bioinformatics core. But besides that, I thought it was a glowing hit.
Can I ask a question?
It's exciting to hear, Satish, because I think this was what Peter had pointed out to us, is this is a real lack at our institution. So thank you. Go ahead.
No, sorry. I just wanted to have a quick question following up what Satish was saying. So the pharmacology core is basically an existing group or core already, and they're devoting currently sort of 5 to 10% of their time to the CFAR core. There's not sort of a specific leader that is going to do the CFAR core, except for that young investigator that they're trying to bring in and build up a cure agenda there. How is that? Yes, exactly. And the question is, how is that being viewed? Is it necessary to have sort of a stronger personnel commitment here, or is that perfectly okay? Because I think it also reflects potentially the need that we will have in the in CFAR to use that core. But I wanted to bring it up because I didn't know if that's a plus or a minus.
Peter, do you want to comment? I mean, we had asked for a senior and junior, and I think Fran is still, but do you want to comment on that?
Yeah, I mean, I think it's just, it was just put in, that's to be responsive to what we asked, to have, junior leadership. And I think that, the roles will evolve over time. As Amelia charts out her own research agenda, but I think this will be an area of ongoing discussion.
I was more thinking how
Melanie, we should stress it senior.
Yeah, right.
I mean, you're right, Melanie. I think you're pointing out that we had asked for a junior, but not just a junior, but a junior and a senior of each. So Fran will still be listed as the senior.
Yeah.
And I think she is. I just wanted to sort of see, and I mean, maybe we can just make it look on paper more that there's a sort of a more exclusive commitment to the core and not just sort of a tangential.
Yep.
I mean, this is a great question because what we haven't done yet, and we'll be doing it tomorrow at our leadership meeting. And Lauren, I forgot to ask you to do this, but please put the budget requests from each subcore together, including the clinical core, which I knew was going to give it to us since we talked to them. But, we don't want to go over budget. And the idea, if you support both a junior and a senior, could actually increase our budget. So it's a very good point that we did that to encourage early stage investigators, but we don't actually want to spend all our money on people. I mean, we have to be wise.
Well, and I think there's also the key, I mean, depending on what services the cores provide, the majority, how you structure personnel costs differs based on who's actually providing the services. And so, you may have senior leadership that's overseeing, for example, a data analyst who's processing data sets for investigators or processing.
And the senior leader doesn't get support per se.
Or just a small amount, so I think, we'll have to look into exactly what folks requested. And I'm sure there's going to be budgetary changes based on the applications that were submitted to fit the mechanism, but we haven't done that yet.
But I was just also wanted to point out that if there's a sort of like 5% effort budgeted also for people who are working in there, the question is, do we only get 5% of the services? And is there a restriction for the access that Satish was pointing out? Is that going to be still prioritized or not? And I just wanted to make sure that it looks perfect to the reviewers when it goes, when it goes into the grant. And I think it might be worth a discussion how to structure this and make sure that reviewers are confident that these are cores that will primarily support the CFAR enterprise.
the value added needs to be absolutely explicit. Yeah.
Can we even describe with percentages or some actual numbers in terms of like what kind of percent of the core's activity will be specifically devoted to CFAR activities?
For those cores that serve investigators outside of the field?
Yeah, where there's like a shared facility, like being able to make some claims or put some numbers there, I think would be helpful. And the other thing, this would be more retroactive than proactive, but as I mentioned in my review, I think one thing that would be important is like, for a new core, like the bioinformatics core, that's a shared resource, setting up a polling or something. So, periodically polling our CFAR investigators to see if they feel like they're getting a return on investment and they're actually getting access to the core resources as needed, to use that to kind of evaluate the core in real time.
Mm-hmm. That we have done, and we actually should do this in advance of the renewal. Do people like Diane, Susan, Carol, Karina want to comment on what they reviewed?
I can make a quick comment. I was lucky to review the biomarker subcore, which is part of the biobehavioral one, which I love the name of. And I think what really struck me was just the really innovative nature of developing the substance use biomarkers for long-term sort of for gathering that data. And I think it just intersects so nicely with the new substance use core. And so it was very exciting to see that, as well as continued ongoing support of the HAL Lab of many CFAR investigators. And so anyway, just to say that it was, I think, really a central feature of this biobehavioral core, and made some other comments too, but all very exciting. I think the only other thing is just highlighting some of the, as I was revisiting that the CFAR sort of the cross-cutting themes and all the international work that is highlighted, but just explicitly referring to it as part of the cross-cutting themes, just to make it even stand out. So things like that. But it's very, very exciting.
Mallory, do you want to comment on, and Carol, substance use and biomarkers? That was great, Karina. Thank you.
Sure. I mean, I maybe what Karina just said is particularly salient. I think as all these go forward and as the structure is much more solid for the people who are writing the various components, we'll be able to make these cross-core, cross-SWIG, cross-component connections much, we can be very vigilant about that. So making those ties between the substance use subcore and the biomarker subcore or program, whatever we're calling it, laboratory, those things will be able to really build that carefully. I also looked at the intersectionality SWIG, and I gave some comments on that, but I don't know how much detail we want to go in there. And that was another one where I thought there's really an opportunity to tie together the various moving parts in a way that's going to be cohesive and coherent and really synergistic and build things. And really making sure that when we're talking about cores and programs, we're really being clear about the services that are offered and provided. For example, with intersectionality SWIG, there were lots of things that were very much in line with what the purpose of a SWIG is in terms of stimulating, bringing people together, stimulating new research. There was also, I think, times where it veered a bit too much into providing training clinicians, which I think is much more downstream and not quite what the purpose of a SWIG is, much more on the initiating research and cultivating and stimulating research, as opposed to translating that to clinical practice. So really kind of making sure we have the some consistency and clarity about what the scope and range of activities are among the various parts, consistent with the mission of the CFAR program.
Monica, this is Carol. And the only thing, well, I want to add two things. One around the substance use and biomarkers. To me, that is something that, even though we have a lot of substance use research on this campus, and we're talking more about focusing on HIV pieces, but the whole biomarkers piece in substance use is an area that has a lot of growth potential. And so it is really exciting. That's all I have to say about that. I do want to comment briefly on the intersectionality working group, SWIG, which, so hearing you say what you did, Mallory, is helpful. I think it's very important, and I see, you know, and what's the definition and how does it interact with these other pieces, right? And of the proposal as a whole, but it wasn't clear. It had some vague pieces, and I got confused about the clinical training piece also, because I thought, well, where is that? But I didn't go deep into it, but it something about it feels unclear, and in terms of the scope of it and the focus of it, and I think it could benefit from, you know, just being clear about what the CFAR is, you know, what's the work of the CFAR, that's all. I don't have anything else to add. You could just go on.
Monica, I'll just give you my 3 comments. So in the clinical, we need a clinical cohort, and there just needs to be, it's the details of that cohort that needs a lot of work, and the balance between the very established, wildly successful cohort of scope options, and then the new prevention cohort, and leadership and diversity. It just, but I mean, I just put those comments on. I don't think the group needs to hear those. For climate change, I feel like Sherry is just like so much expertise, so scholarly. I just don't know with CFAR, like there's a lot of data on international. It's just the question is this something that CFAR supports? And that's more like my lack of knowledge about that. But Sherry Weiser per se, and the work that she does on climate change is so exciting and so forward thinking and so important globally. And I would just like to echo, I think we just want to make sure anything that we have on doesn't bring the grant down, just in terms of the intersectionality. Just my reaction to, oh, let's train clinicians so they know what they need to do in this. That just is not like, doesn't resonate at all. And I don't think anybody would disagree. The concepts in intersectionality are so important, but I think we have to be super careful that, as the last 2 folks said, Carol and Mallory, that it fits into what a CFAR should be doing.
Yeah, thank you so much, because those are the 2 I also am more worried about. I'd love to hear Carol and Susan's thoughts about housing, but we have to just make intersectionality clear and not, though the work is great, not bring in anything controversial that could bring anything down, because it's so dumb that it is, but it is. So the climate change, we're thinking about that. And we did talk to the NIH, but we only talked to the program officers. I think we had to explore, like anytime Peter and Mallory, you're talking to someone, like, does any other CFAR have this? Is there something that we could do to ensure that it doesn't bring the review down? To mention something that still that's not been supported by the NIH and RFAs, for example.
Yeah. Monica, one more thing that might be helpful to mention is that I don't have the date in front of me, but we have our appointment, our schedule.
February 22nd, I think, yeah.
Next month, we have a 2-hour block, I think, with NIAID program staff to present some of these ideas. So that'll be a good opportunity to get feedback, and if the IAB has particular questions or ways to frame our questions that would be most productive, that would be great. So we're certainly compiling everything we're hearing here to that end, but just also, yes, you know, that's coming soon. So we have this other opportunity for input.
It would be great, because I saw Joel came on, but maybe could I ask first the housing? Susan, your thoughts?
Yeah, so I think that the issue of housing and its impact on HIV is really critically important. I would have liked a little more specificity in the proposal itself as to what they were and I wavered a bit about it because it is such a critical issue, but it wasn't completely clear to me what the content was in that particular SWG. So I think it would need to be fleshed out a little bit more.
Yeah, those three, I saw the weaknesses with that. Thank you. Okay. Carol, same.
Yeah, just ditto. It's like, is it I mean, the whole idea of epidemiological leadership and then intervention development, but how do those mix in terms of housing? I mean, I think they make an excellent case, and we all know the evidence about housing and the impact on everything, acquisition and
it's not
outcome,
enough just to say something is horrible.
right? And that's what is.
What do you do about it? Yeah. Okay.
Yeah.
So, yeah.
Could I ask Joel, I'm not sure if I didn't see you before, but do you have any comments that you want to make, Joel, about specimen bank? And Peter also reviewed the specimen bank. That's kind of our last one that we haven't mentioned.
Just very briefly, I gave the specimen bank the high impact score, not necessarily on the quality of what was provided.
Yeah.
But rather on the essential nature of the thing. I mean, what was provided was, well,
got to work on.
It wouldn't have been. It
yes. I was less generous, Joel. So I think.
Okay, we got to work. Yeah, we got to make that section in the grant better than what was written.
Much better.
Yeah. Okay. Unless anyone else has anything burning, there's 3 major decisions that I would love to hear from the group. So does anyone else want to say anything about their reviews? Okay, the 3 major decisions are the name. So Joe Watabe sent you a Qualtrics poll, and there were suggestions, and then you could fill in your own. And the name was basically either UCSF Bay Area CFAR got the most votes, and then UCSF CFAR got some, and then no one had filled in anything that was like consensus. I just wanted to hear if people liked that name or there was any other new idea. This is changing, Melanie, from UCSF Gladstone CFAR, since Gladstone is one of our affiliates, but do people like it? I mean, if you all voted for it, I assume you do, but
what is the top hit again?
UCSF-Bay Area CFAR.
Yeah, I thought that was the best.
Yeah.
Okay. I thought maybe someone would have some wildly innovative idea, but that is okay. I mean, it's UBAC, UBAC. But I think it's representative. I mean, we want to be inclusive about our partners across different bridges. So, okay, so that's going to be the name. Then the second thing I want to see if you would have input on, it's really just 2 more items, is one is, I think you see how there are 3 more things actually. So you see on here that there are these cross-cutting areas. And I did take to heart, I think, Margarita, that you said, try to make the cross-cutting so it's like encompassing like a circle instead of triangles. And I really tried it and it just looked horrible. I don't know, I'm just not a design. I'll see if someone can help me design this better, like someone who's good at graphic. But what about choosing or transparently putting out a call for leadership for those 3 cross-cutting areas prior to the renewal? Or do you think that is something that should be done after the renewal? So this is a general question I ask you. And also, should they each have leadership? Health disparities in community engagement, training, and international.
Monica, I think I asked you this last time, but how do you see these 3 areas intersecting with the various things that are represented here? Like, is there some geographic overlay, or is training relevant to everything on here, or just a sector? Like, how are you envisioning these relationships?
Only health disparities and community engagement we tried to localize with the clinical core and biobehavioral cores as being more over there. But otherwise, actually, they were all supposed to be represented in every single thing we do, which is why each of your concepts that you reviewed should have had mention of each of these areas per the instructions. So it really, that's why I'm sure we can find someone who does better graphics, and represent that better. But right now they're triangles, but they're supposed to be cross-cutting means across the entire thing. So where does community engagement comes from? That is actually specifically mentioned in the RFA. Disparities has always been a part of us. Training is really important to us, and international. We had received after the deadline a subcore proposal, but by that time we had already decided on having it be represented, suffused through all of the subcores.
I mean, I think, Monica, your question, I don't know what the right answer is about leadership in terms of across these pieces, and is it better to name it now or later? I do think that, especially around the health disparities and community engagement, because that's what I'm more familiar with, that it's important to have it be active instead of, yeah, we all need to address it. You know, that sort of idea is just, it's not okay, right? So it might be helpful to have in some way leadership identified. And I think you have John identified in as one position. So I don't know if that would be this one or, so anyway, that's my thoughts.
Well, yeah, and Karina is Associate Director of Equity, but I think we're going to be changing that up. And so Karina and John are obvious, you know, people over here, but so are people in CAPS and the School of Nursing that work actively on this. I mean, a call would be a call, you know, and putting out a call, but the question is like saying we're going to identify leadership. I actually agree. Margarita, you said this to me on the phone. You said if without a leader, it will just look like you're paying lip service. Right. Is that still your thought?
Yeah, I mean, I think in order, you're going to need leadership to really ensure and hold CFAR accountable and help to develop plans to make things happen. Otherwise, it's just stuff that gets tacked on at the end of progress reports. And people don't actively think about it all of the time. In terms of the question around, I like the idea of putting out a call and that transparency around that. And then the question around whether or not to do it now or after. In terms of grantsmanship, I think it always does better when you name someone, because then folks know that it's, you know, reviewers know that it's real, and then it helps them to decide whether or not it makes sense. If it's TBN, I think it's not reviewed as well.
Yeah.
They can also help write that section.
Yeah, that's a good point, actually. Okay.
And it would fall in the administrative core then, you know, from a practical point of view, and then be, you know,
that's in the middle,
integrated into all the other core applications. But the structure, the leaders would probably need to be in.
Okay, unless anyone, I totally agree with Peter, and I think Margarita, your point is well taken. If anyone doesn't have any objections, I think it is the right idea to put out a call.
And I had one more comment / question about that I'm keeping an eye on is, so the training cross-cutting area, how it relates to the developmental core, how it's distinct from it, yet complementary to it, because I think that's an area which we haven't had the IAB look at the developmental or administrative cores yet, because we haven't done them yet. But how those relative to each other, I'm anxious to see how that plays out.
It's a great point about training and developmental.
So how does the CFAR mentoring program fit into this whole structure?
Say it again.
Component of the training, or like where does that fit in here?
It's a piece of the developmental core, which is one of the two central cores.
The hot pink.
Okay. So besides grantsmanship, in terms of having like, you a dedicated leader to each of these three areas, is there like a deficiency in performance in these areas that, that we feel would be rectified by recruiting leader? Or is it mainly just the idea of putting a name there so it really demonstrates dedication?
I think health disparities and community engagement has not received the attention. Yeah. I'm not sure about training, because I do think that this CFAR is recognized as kind of a training leader and mentoring, so forth. And international, I wouldn't say that we're not recognized for international, but it's a very good point.
Well, I can, because you always have to walk that line with grantsmanship, even with just writing an R01 or something, where it's like, you don't want to look like you're just putting in a name placeholder to pay lip service to something. There really has to be kind of a clear case for how bringing in new leadership or a team member is actually going to drive part of the work. And I can see what you're saying with the health disparities and community engagement, but I have a hard time envisioning even like, what would like a leader of like the international component be or do? I can't even see what would that.
Yeah, I was also just going to bring that up. Like, what would activities of international, like how would it be related to biomarkers or specimen banking?
Yeah.
Well, I mean, I think internationally based studies that acquired samples and let's just say metadata or phenotype data, and having somebody coordinate that or oversee it or help with the connections, I think it'd be particularly valuable. When I was away, there was an international core that came and went in the CFAR. So I don't know what the history of that was. But it just seems like since so much of the problem is beyond the United States, that it almost would be conspicuous if there weren't an international coverage, let's just say. I mean, I think there are enough cores here, but making international research one of the cross-cutting areas, I think, is actually important. And it could certainly use coordination. I mean, you'd like to know if somebody's working in Thailand and somebody else is working in Uganda and they're working on the same thing. You'd like to find out sooner rather than later.
Yeah. Okay. I think we may send out a poll like with some, I mean, unless anyone else wants to say anything.
Yeah. Can I add a few comments as well?
Yeah, please.
I was just thinking, in terms of leadership structure, I think certainly having a name is fantastic, but I think defining how these leadership kind of cross-cutting cores differ from equity, the larger CFAR Associate Director of Equity position, as well as John's role in the mentorship program and sort of on the training piece, I think will be critical, at least from the grant.
But I think the Associate Director of Equity role wouldn't be kept. I mean, it'd be more like this role, like, you know what I mean? Like, this is the ultimate equity role.
Yeah, I think I think that just clarifying that, like, is the John role, the training role, then, we're sort of trying to figure out how to, package that. So that, I think that would be my other.
I mean, one idea is that we don't put out a call and we have John be the training and you be the health disparities and community engagement, because you've already been selected by a competitive process, and then we just put it out for international. Excuse me.
Yeah, I think, just making sure there's not sort of, or just defining the roles, or that is another idea too, or bringing that up.
You know what? I think I could see a poll coming, because we could ask if people just think the current leaders that, you both were selected in a way by a process, but then again, we also want more nursing. I know we want more nursing representation, Carol, in our leadership. Okay, let's think about that. Like, I want to move on because it's 10:45 and we have two very important things to discuss. So one is clinical core leadership. So speaking of, putting out calls versus just sort of making decisions. So, so we have tried to actually be as transparent as possible with many of our decisions. I will say that the decision about co-directors, of course, wasn't like a poll or anything, but there was a lot that made sense. But there about Peter and Mallory, But Margarita, I don't know if you remember your comment to me, but and you don't have to say it, but we have this disparity question, right, in our leadership at CFAR. And so I am female and and I'm of color in that way, but not from an underrepresented group. But our two other leaders are awesome, white men, and the former leadership of the clinical core was Jeff Martin and Steve Deeks, and so that was two white men, but obvious leaders in their field, I'm stammering over my words because I recognize that it has been an incredibly important thing in all of our positions as leaders on this call to think about diversity, equity, and inclusion, but it's been a particular platform that I guess ran on. So I feel really, this is like a profoundly personal thing for me. The clinical core, however, there had been an impression, and maybe it's by me, that it should be a clinician who helps lead it, and someone who is well versed in clinical research and has NIH grants, but again, a clinician as opposed to a social behavioralist or more on the translational basic science, because there is so much in our division that is linked to these cores. So a thought that we all had, and by all I mean Peter, Lauren, Mallory, and I, along with Steve Deeks, who we consulted with, was to replace Jeff Martin, who actually was very busy with other things, with another clinical core leader, and have two leaders for this, and have that be a woman, but could not, in the current context, could not identify a woman from an underrepresented group. I am very open to comments about this, but the suggestion is Katerina Christopoulos with Steve. And again, I'm open to both criticism and comment, and would like to open this up for your thoughts. I have checked with Kat, and she would be very excited about this role. She is a well-funded NIH researcher, and she also is the new PI of the CNICS, and CNICS has obvious overlap with the clinical core. It is truly a clinical cohort across 8 centers. She leads the one at UCSF, and it has overlap with the specimen core. It has overlap with SCOPE. The specimens were being managed by both Jeff Martin and for both CNICS and SCOPE. She is a clinician. She's a valued clinician. She is a really good clinician. At Ward 86, she would be able to participate in the idea we're developing about Ward 86 referral service. And this is why Kat came to mind. So I'm just fully opening this up for your comments. Not from Peter, Mallory, or Lauren, because we already discussed.
I can start with a comment from the equity standpoint.
Yes, thank you.
And as the Salud Clinic director at Ward 86, I had extensive worked with her extensively on sort of recruitment and enrollment of our patients into the trials. And I would say that her experience in sort of enrolling diverse cohorts, qualitative research, and collaboration with others with Spanish-speaking participants has been so outstanding. And so my just initial thoughts is would certainly from the equity standpoint that would bring a lot of experience in sort of in this realm. So I'm very pro, but those are my initial thoughts.
Her work is truly in vulnerable populations.
I think, in terms of racial ethnic diversity, and then also really extensive experience in sort of unhoused population. And so I think that would add a lot to this, the core, the clinical core.
Diane, I know you're her division chief, but would you be willing to make a comment?
I think I think Kat definitely has the credentials, and I honestly think Karina's input is absolutely critical to the decision. I would support it.
I find this exciting.
Thank you. Could I get any other commentaries? Believe me, Susan, for example, I had approached and thought about Hyman. He's not in our division, but Hyman is really, he's very busy.
He's stretched, yeah.
Yeah, and I really do need someone who, I think, like Peter and Mallory, really do. Kat sort of is the type of person who, if she commits to something, she will do it.
I mean, I think Kat is a great choice, and I think Monica, in your role as the director, and then in our role, it's our bench isn't very deep, and that's just a problem, right? It takes years to build it, and it's something that needs to be addressed. Kat, I think, is an excellent candidate, though, for the reasons that have been said already.
Thank you so much for acknowledging, Carol, that gives me great pain that our bench isn't that deep. And I think it gives everyone on this call pain. So it really wasn't an option that I could find.
I think it raises the other point of a part of the grant needs to be a genuine plan about bench building.
Uh-huh. Yes. That lament I can bring from my childhood. So, okay, that lament will be there. Unless anyone else has any other comments, I actually wanted to move on to the final decision. And I really need your input on this, which is external advisory board members. So okay, I'm gonna, and please feel free to email me if there's any other comments on this question that we wanted to run by you. Okay, now I'm going to do this in real time and get your thoughts. These are the current external advisory board members. Some can come out, some can stay in. It's up to you. Thoughts? I mean, there are some people who we really like, some people who maybe some of you think, wow, I don't see cancer represented as well, which is in some of our stakeholder member meetings that was brought up by Joel Palevsky. So you want to bring in a cancer specialist. I don't think this is represented that well. Mike Sagg's great, but he was BFFs with Paul, like whatever you want to do. So this is an open meeting. Anything you guys want to say? Who do you want in? Who would your thoughts be?
I just have a quick question, Monica. So
yes.
In the application, you're required to name the EAC?
Yes.
Okay.
Oh, I believe so. Is that true?
In the P30 application, we weren't allowed to.
I'm not sure, actually.
You're not supposed to name them.
We named them last time.
That's interesting. You would think you'd have the same rules as your P30, though. But we did name them last time. I still want to invite them.
So did we. They changed the rules.
They changed rules. Okay, yeah. And also, we could still invite them even if for some reason they're not on here. But like, your thoughts are really key. We have good basic science representation on this IAB. We have good diversity representation for.
It does actually say not to contact or name them in the application.
Okay.
If they're potential or proposed.
Yeah, I think they do that so they don't lose more of the reviewer pool.
Because that makes sense.
Yeah. This is a new requirement that wasn't there last time.
Okay, thank you. I mean, we still do have 5 minutes, and I love the valuable time that we have together. So I'd still love to hear your thoughts.
Could we increase further the diversity and potential the women part?
Yes, and we can also take people out. I mean, I don't see why we have to keep the same one.
Yeah, and I also think we should look at our configuration. The plan changes, and the emphasis on the biobehavioral core and the emphasis on substance use and making sure that we have some people who can give input in those domains.
Great thought. And if there are names, because you all work so closely with people that are like really coming to your mind, please name some names.
And are there any members of the present group that just don't show up or not very helpful? Or is everybody
Lauren?
pretty similarly involved?
Yeah,
Lauren
not
would
very
know that.
engaged.
Well, we haven't had we had a meeting, I think in 2017, and then that was the last meeting. So they haven't really had that many opportunities to be engaged. I mean, I think, you know, the chair did a really nice job. I mean, it was a good meeting. You know, I think it's more just that they haven't had the opportunity.
I would love to see sort of some basic cure researcher more represented there, but have to think about somebody, especially in the female category.
Yes.
I agree, and also maybe subbing out Mario, for as one person who might be replaced.
Okay,
Other
excellent.
women would be nice.
Any thoughts though? I mean, really, we have 3 more minutes, and it's so hard. We only meet every other, so people can say like, oh, I really like this person, and this person I think is okay to put down, bring down off the list.
I think it might be helpful to have for our areas that are new that we haven't had in the CFAR before, so particularly substance use and bioinformatics.
Thoughts on substance use, Mallory? Yeah, you had said that as well. Like, let's think about our areas that we have now. So thoughts of a great external substance use expert. I would also want to ask you about cancer.
Steve Shoptaw gives good consultation, but it doesn't help us with our diversity.
What about Stephanie Strathy?
Oh,
yes, yeah, that is a great thought.
Awesome. Yeah.
And she would also help with the international. I mean, a few.
That is a great thought.
Yeah.
While you're thinking about substance use, think about cancer too. We can send out a poem, people can think of names, but if anything else comes to mind, I really like this Stephanie Strathy idea, if she agrees.
I agree. I think she's great. I think she would be a great advocate for us also elsewhere. I'm thinking about people from the Yale group. They have several good female investigators there also. I can come up with more concrete names, but I don't know. What about Elizabeth, Beatrice Hahn, also somebody who's sort of a little bit more prominent, but not necessarily exactly what we do, but and then and Satish, you collaborate a lot with Betty Korber, no? She would also be a great
absolutely
a great person here. So I think there's several sort of prominent women that we should consider.
Susan, prevention at UW. I'm sorry that I'm forgetting.
Is there somebody you had in mind?
Julie, not Julie Dombrowski, but
you're not talking basic, you're talking prevention.
Yeah, prevention science. On the cutting edge. Diversity. Maybe not just UW.
You're not talking about Julie Dombrowski.
Well, I think I am. I don't know what you think of that. That would be interesting for housing and disparities.
Yeah, I think so. I guess I'm just also, given that we just talked about not having a lot of diversity in the core, I guess I'm just wondering about thinking a little bit more about diversity.
Yeah,
I mean, the other person I just know for substance use might be Ricky Blumenthal.
Ricky?
Yeah, he's at USC.
Okay, since it's the hour, I want to stop us exactly on time because I know people are really busy. We can think of other names, and that may come out in a poll where you have some suggestions. Okay, thank you all so much for all your contributions. They were huge today. Thank you very, very much.
Thanks, everybody.
Thanks.
Bye, everybody. Bye.
Bye.
Hey, Monica, just super quickly. Frank is finalizing the spreadsheet to compile the budgets, but I don't think it's ready for tomorrow, but I can have it for the 1 and 2 weeks.
Okay, that sounds good.
Or like we could, or maybe even for next week, I'll just check in with him, but I know that he was finishing it up. But
Did you get the clinical core?
Did I get the clinical
one from
core?
Steve? You know how 2 weeks ago we talked to him on a Friday afternoon at 4?
He didn't
and
send
said
me
that-
the budget. Did he send it to you?
No, can you ask him again
Sure.
that we need that budget?
Yeah.
So that we'll have it ready
Yeah.
for when Frank compiles. Okay, thank you.
Thank you. All right.
Thanks. Okay, bye.
Bye.